Every single day, in hospitals all around the world, doctors inject patients with a chemical derived from a drug that is, well, it's responsible for over 80,000 accidental American deaths every year.
Yeah, it's a staggering number.
It really is. I mean, it is the ultimate medical paradox, right? A drug that is both an absolute compassionate necessity and simultaneously a mass killer. So, welcome to a new deep dive. We are super thrilled you're joining us today.
You really just cannot practice modern surgery or complex trauma care or, oncology without these medications. They are pretty much the absolute backbone of severe pain management.
Right.
And yet managing them requires walking this incredibly tightrope over a very steep cliff, because the very mechanism that brings all that relief is inherently tied to a fatal shutdown of the body's respiratory drive.
So here is the mission for this deep dive. We're going straight into our source material to examine the pharmacology of opioid analgesics. We're going to look at exactly how they relieve pain, the precise mechanism of how they stop breathing, and how a life-saving reversal drug actually works at the microscopic level to pull someone right back from the brink of death.
It's a lot of ground to cover, but it's so important.
Definitely. And to do that, okay, let's unpack this. We have to immediately correct a massive misconception that you see in the news, like every single day. The media constantly talks about the opiate epidemic.
Yeah, constantly.
Right. But technically, almost from the very start of this crisis, that phrase was just completely wrong.
It is, yeah. It's a crucial pharmacological distinction that just completely gets lost in the public conversation. The terms opiate and opioid are treated as synonyms, but structurally, they are entirely different categories. So break that down for us. Well, opiates with an ATE refers strictly to the naturally occurring alkaloids that are extracted directly from the sap of the opium poppy, the Papaver somnifera plant. And that list is actually remarkably short.
We're basically just talking about like morphine, codeine, and the bane, right?
Exactly. Those are the opiates, just the chemical compounds produced by nature. But opioids with an OID at the end is the broader, overarching umbrella term.
Okay, so it covers a lot more ground.
Right. It covers any compound that binds to the opioid receptors in the human body, regardless of where it came from. So this includes semisynthetics, where scientists basically tweak the natural plant molecules to make drugs like oxycodone or hydrocodone.
And it also includes the fully synthetic ones.
Yes, and that is the critical part. Fully synthetic drugs like fentanyl and methadone. Those synthetics share absolutely zero chemical ancestry with the poppy plant. They're created entirely in laboratories.
Wow.
And the reason this matters for you to understand today is that the deadliest drugs driving the modern overdose crisis, well, they aren't opiates at all.
They're entirely synthetic opioids. It's wild to think about how far we've come from just the natural plant. And I mean, to truly grasp how these powerful synthetic molecules operate, we kind of have to look back at how humanity discovered their natural predecessors.
History gives us a lot of context here.
It totally does. The timeline in our sources starts all the way back in like 3400 BCE in Sumeria. Archaeologists actually found cuneiform tablets referring to the poppy as hulgil, which translates directly to the joy plant.
And we see that through line across so many civilizations. Its medical use is heavily documented in ancient Egyptian text and classical Greek medicine.
Right, but for thousands of years, practitioners were simply using crude opium, weren't they?
Exactly. They would score the seed pod of the poppy, collect the milky latex, and just use it as a raw substance. They completely understood the effects, the pain relief, the sedation, the constipation, but they were completely in the dark regarding the actual active ingredient driving those effects.
Which brings us to a really pivotal and frankly kind of terrifying moment in 1804. So there was this German pharmacist named Friedrich Serturner. He was working in his lab, and he actually managed to isolate the primary active alkaloid from that crude opium sap.
And he named it morphine.
Yes, after Morpheus, the Greek god of dreams, because of its incredibly heavy sedative properties.
Right.
But here's the crazy part. He doesn't just write a paper about it. He decides to test it on himself.
And on 3 of his young, unconsenting assistants. Right.
Yeah. What I struggle to understand is the sheer recklessness of it. He administered this massive, uncalibrated dose of this newly isolated, highly concentrated chemical to himself and these teenagers.
And it predictably caused near-fatal respiratory depression.
Right. They all slipped into unconsciousness and almost died. He reportedly had to revive everyone by aggressively forcing them to drink like large quantities of vinegar to induce vomiting and stimulate them.
It's just astonishing.
It is. This 1804 self-experiment is one of the very earliest recorded medical encounters with the exact same mechanism that kills overdose victims on the streets today. And yet, even after he isolated morphine, and it went into massive worldwide medical use, especially during the American Civil War when they paired it with the hypodermic needle, science was still operating totally blind.
Yeah, for well over a century, clinicians only defined these drugs by their outward clinical effects.
They could observe the pain relief and the euphoria, but they were essentially just guessing at the invisible machinery operating inside the human body.
They assumed there had to be a biological target, a receptor of some kind, but it remained entirely theoretical. And what's fascinating here is that we didn't actually prove the physical existence of these receptors until 1973.
That timeline is just staggering to me. We were landing human beings on the moon before we had definitive proof of how morphine actually functioned in the human brain.
Right. In 1973, a researcher named Solomon Snyder and his graduate student Candace Pert at Johns Hopkins achieved this massive breakthrough.
How did they finally prove it?
To prove these receptors weren't just a theory, they used radioactively labeled opioids and applied them directly to rat brain tissue. Because the opioid molecules were radioactive, they could physically track exactly where they accumulated.
Oh, wow, so they can actually see it.
Exactly. They demonstrated stereospecific binding sites in the brain tissue. For the first time in human history, there was direct, undeniable evidence that opioid receptors were real, physical, anatomical structures in the central nervous system.
And the evolutionary implication of that discovery is just profound, because if human beings and rats and mice all possess a highly specific, complex physical lock, perfectly shaped to receive a chemical key derived from a random flower, why would we have that?
Right. Human biology wouldn't evolve a highly specialized receptor complex and just let it sit dormant for millions of years, waiting for the opium poppy to invent the key.
Exactly. That realization led to an immediate secondary hypothesis, right? The body must manufacture its own internal version of the drug. We must produce endogenous opioids.
And that was proven true just 2 years later, in 1975, when Scottish researchers John Hughes and Hans Kosterlitz discovered enkephalins.
Those are our body's own opioid molecules.
Yes. Later, researchers identified endorphins and dynorphins as well.
So morphine isn't some magical external cure-all that the plant graciously provides. It is simply a chemical mimic. It literally hijacks our body's pre-existing internal pain relief system.
The hardware is already built into our nervous system to manage stress and pain. The external drugs just flood that system with a volume of chemicals it was never designed to handle at once.
But if these drugs are just utilizing a natural biological system that we already possess, why are they so incredibly lethal? That brings us to the core mechanism of the mu-opioid receptor, which is frequently abbreviated as the MOR.
To really understand the lethality, we have to look at the cellular level. Opioid analgesics act as agonists at G-protein-coupled receptors.
Okay, getting into the chemistry here.
Just a bit. When an opioid molecule binds to that mu-opioid receptor on a neuron, it triggers a cascade of intracellular events. It inhibits adenylate cyclase, it closes voltage-gated calcium channels, and it opens potassium channels.
Hold on, we need to translate that chemistry into something a bit more visual for the listener. What is actually happening to the nerve cell when all those channels open and close?
Okay, think of a nerve cell, a neuron, like a charged battery that sends electrical alarm signals. When the opioid binds to the receptor, it essentially opens the floodgates for positively charged potassium ions to rush out of the cell.
Okay, so the potassium is leaving.
Right. As the potassium leaves, the neuron loses its electrical charge. It drains the battery. And because the neuron loses that charge, it literally quiets down. It becomes far less excitable. And crucially, it stops releasing pain-signaling neurotransmitters, specifically substance P and glutamate.
It basically unplugs the alarm system.
That's a perfect way to put it. In the dorsal horn of the spinal cord, this silencing effect effectively blocks pain signals from traveling up to the conscious areas of the brain. That is the profound analgesia that makes surgery possible.
And what about in the brain itself?
Well, in the brain's reward pathway, particularly the nucleus accumbens, this same receptor activity triggers a massive release of dopamine. That creates euphoria, which drives the intense addiction potential.
Right.
But crucially, this exact same quieting effect happens in the brainstem, specifically in the medullary respiratory centers, which control your automatic, unconscious drive to breathe.
And here's where it gets really interesting, because I think a lot of people fundamentally misunderstand this part of the pharmacology. When you take a medication, you usually have the therapeutic effect, and then you have accidental side effects.
Right, like taking an allergy pill.
Exactly, like you take an antihistamine to stop a runny nose, and the side effect is you feel drowsy. But the pain relief happening in the spinal cord and the respiratory depression happening in the brainstem, the thing that stops your lungs from moving, they are not separate things.
No, they aren't. And it is a vital concept for anyone handling these drugs to grasp. Respiratory depression is not an allergic reaction. It is not an unintended side effect.
They are two faces of the exact same biological mechanism, right?
Exactly. The drug is doing the exact same thing, silencing neurons by draining their electrical charge, just in different geographical locations of the central nervous system.
Which means there is no such thing as a perfect opioid that kills pain entirely, but carries zero risk of stopping your breathing. The biological lock and key are identical.
And this mechanism is so perfectly reliable that bedside nurses, paramedics, and emergency physicians use it to spot an overdose instantly. They don't even need a blood test.
They look for a specific physical pattern.
Yes, they look for the opioid toxidrome triad. Toxidrome is just a portmanteau of toxic syndrome. First responders are trained to look for 3 simultaneous clinical signs.
Okay, what's the first one?
First, profound central nervous system depression, meaning the patient is unresponsive, lethargic, or entirely unconscious. Second, respiratory depression. And third, meiosis, which refers to symmetrical pinpoint pupils.
And if a patient presents with all 3 of those,
If they have all 3, it is considered almost entirely diagnostic of an opioid overdose.
when we talk about respiratory depression in this context, we really need to be crystal clear about what that actually looks like in an emergency. Our sources highlight a 2018 clinical review analyzing EMS naloxone administration across Massachusetts.
What did they find?
They documented that overdose patients were frequently found breathing just 4 to 8 times a minute.
Oh, wow. To put that into perspective for you, a normal resting adult respiratory rate is anywhere from 12 to 20 breaths a minute.
So these patients are taking a single breath every 10 or 15 seconds, sometimes even less. It's a phenomenon called agonal breathing.
It sounds like snoring or gasping, doesn't it?
Yeah, but it is actually the brainstem struggling to send the signal to the diaphragm. It perfectly illustrates how razor-thin the margin is between a therapeutic dose that sedates a patient for surgery and fatal apnea where the oxygen supply is simply cut off.
With a margin of safety that narrow, the pharmacology just becomes a numbers game, which is why we have to discuss drug metabolism, because not all opioids are created equal, and how the body breaks them down can be really unpredictable.
Okay, give us an example.
Consider codeine.
That brings up a massive myth we need to dispel. There is a persistent belief that codeine is a weak, harmless option. It's often thought of as this mild opioid historically prescribed in cough syrups for kids.
Codeine is what pharmacologists call a prodrug. By itself, in its original chemical structure, codeine has incredibly low affinity for the mu-opioid receptor. It basically does nothing.
Wait, really?
Yeah. However, your liver acts like a chemical refinery. When you swallow codeine, it travels to the liver, where a specific enzyme called CYP2D6 strips away a methyl group, chemically transforming that codeine directly into active morphine.
So you aren't really taking codeine, you are taking a delayed-release morphine pill.
Exactly. And the danger lies in genetics. Because of genetic variations, some people possess multiple copies of the gene that creates that CYP2D6 enzyme. They are known as ultra-rapid metabolizers.
Meaning their liver processes it faster.
Much faster. Their liver runs that chemical refinery at 10 times the normal speed. So if you give a standard, supposedly mild dose of codeine to an ultra-rapid metabolizer, their liver instantly transforms it into a massive, overwhelming spike of morphine in the bloodstream.
That's terrifying.
It is. People, including children recovering from tonsillectomies, have literally died from standard prescribed doses of codeine simply because of their genetics.
It's why the FDA ultimately slapped a black box warning on codeine for pediatric use. And this variation in drug strength becomes even more terrifying when we move from natural opiates to the fully synthetic opioids flooding the illicit market today. The milligram for milligram potency differences are just staggering.
To visualize the potency scaling for you, 10 milligrams of intravenous morphine is roughly equivalent in pain relief to about 100 micrograms of intravenous fentanyl.
A microgram is a significantly smaller unit of measurement.
Yes, this means fentanyl is roughly 50 to 100 times more potent than morphine by weight.
To picture that, a lethal dose of fentanyl is roughly equivalent in physical size to just a few grains of table salt, which really emphasizes the sheer terror of the illicit counterfeit pill market.
Because a tiny error changes everything.
Exactly. A microscopic visual error in how a counterfeit oxycodone pill is pressed in a clandestine lab, just 2 or 3 extra grains of salt worth of fentanyl, transforms a recreational dose into a fatal one. And the source material also mentions carfentanil, right?
Yes, that's a veterinary tranquilizer designed for large animals like elephants, which occasionally contaminates the street supply.
And that is estimated to be 10,000 times more potent than morphine.
It is active in the extreme microgram range. It completely overwhelms the mu-opioid receptors instantaneously.
The obvious question is, how did we get here? How did the United States transition from a medical system where opioids were closely guarded hospital medications to a crisis landscape where over 80,000 people are dying annually?
A significant catalyst in that historical shift involves the launch of OxyContin by Purdue Pharma in 1996. Purdue aggressively marketed the sustained-release formulation of oxycodone for long-term outpatient management of chronic non-cancer pain,
Right.
and to convince hesitant doctors that prescribing powerful opioids for backaches or arthritis was safe. Purdue sales representatives heavily promoted the idea that the risk of addiction was less than 1%.
The origin of that less than 1% statistic is genuinely shocking. The source material traces it back to a 5-sentence letter to the editor published in the New England Journal of Medicine in 1980.
5 sentences.
Just 5 sentences. It wasn't a peer-reviewed study. It wasn't a clinical trial. It was just a brief observation describing extremely low addiction rates among hospitalized patients receiving short-term opioids under strict medical supervision.
Right. It described a highly controlled clinical environment that had absolutely nothing in common with handing a patient a 30-day prescription to take home unmonitored.
But they ran with it anyway.
They did. That single misused citation was repeated in academic articles and marketing materials hundreds of times over the next 2 decades. It became the foundational piece of evidence used to justify a massive cultural shift toward aggressive prescribing.
And part of how they justified that shift was by exploiting another major misconception, right? Conflating physical dependence with addiction.
This is a critical distinction that medical science really failed to communicate properly. Physical dependence is a guaranteed physiological adaptation. If you take opioids for a sustained period, your brain receptors adjust to the new chemical baseline.
And if you stop?
If you stop abruptly, your body will go into severe withdrawal. Anyone's body will do this, regardless of their psychology. Addiction, however, formerly known as opioid use disorder, is a separate behavioral and neurological condition. It's characterized by compulsive drug seeking and use, despite devastating harm to the person's life.
By blending those two concepts, pharmaceutical companies could argue that patients weren't experiencing addiction, they were just experiencing pseudo-addiction or physical dependence.
Which could supposedly be solved by prescribing even more opioids.
Exactly. Our sources document that this aggressive marketing eventually led Purdue Pharma to plead guilty to federal criminal charges in 2007 and again in 2020 regarding their misbranding practices, which resulted in sweeping civil litigation and bankruptcy.
If we connect this to the bigger picture, though, it is vital to understand the clinical debate that preceded that marketing push. Before the 1980s, pain was genuinely chronically undertreated across the medical system.
Especially for cancer patients.
Yes. Doctors harbored such an exaggerated fear of creating addiction that they were literally letting patients die in agony.
Palliative care pioneers recognized this tragedy and fought to change the standard of care. This led to the 1986 World Health Organization's analgesic ladder, which established a stepwise approach that finally legitimized strong opioid use for severe cancer pain.
But the pendulum swung way too far. In the late 1990s and 2000s, heavily influenced by campaigns labeling pain as the fifth vital sign, the medical community swung into massive overtreatment.
Using opioids liberally for chronic everyday pain, which triggered what the Centers for Disease Control and Prevention calls the 3 waves of the opioid crisis.
Wave 1, starting in the late 90s, was driven entirely by those prescription pills.
But Wave 2 is where the unintended consequences of policy really show up. Around 2010, the government cracked down on pill mills. They reformulated OxyContin to make it harder to crush and snort, and they restricted prescriptions.
And because millions of Americans were already physically dependent on those pills, cutting off the legal supply didn't cure the dependence. It simply forced those patients into the illicit market, causing a massive transition to street heroin. That was Wave 2.
And Wave 3, starting around 2013, is the landscape we are in now. The illicit supply chain realized that smuggling plant-based heroin was bulky and expensive.
Synthesizing fentanyl in a lab was incredibly cheap, highly concentrated, and so easy to transport.
Now, the illicit supply is almost entirely dominated by illicitly manufactured synthetic opioids.
Today, the clinical pendulum is finally swinging back toward a cautious, conservative approach called opioid stewardship. The medical community recognizes that debating whether opioids are inherently good or bad is just useless.
The real clinical question is always about careful patient selection, minimizing the dose, shortening the duration, and aggressive monitoring.
Because if you are waking up from a traumatic injury or a major surgery, you absolutely want that mu-opioid receptor activated.
But with the margins so incredibly thin, what happens when it goes wrong? When a patient or just a bystander on the street crosses the line into respiratory depression, how do we reverse it?
That is where the ultimate pharmacological antidote comes into play: naloxone.
Often recognized by the brand name Narcan, it was synthesized back in 1961 by chemists Jack Fishman and Moses Bloomberg in a small New York laboratory, and they designed it to perform a very specific function: to be a pure competitive antagonist.
To visualize how a pure competitive antagonist works against an agonist like fentanyl, we can look at the receptor mechanics.
Okay, think of the mu-opioid receptor like a high-stakes game of musical chairs. You have the chairs, those are the physical receptors situated on the neurons in your brainstem. The opioids, whether it's morphine or fentanyl, are the players sitting in those chairs. As long as they're sitting there, they are draining the battery, silencing the neuron, and turning down your breathing. Now, you administer a dose of naloxone. Naloxone is like a hyper-aggressive, incredibly strong player who bursts into the room, violently shoves the opioid out of the chair, and this is the absolute key to the entire drug, naloxone does not sit down itself.
That analogy perfectly illustrates the binding affinity. Naloxone has a stronger affinity for the mu-opioid receptor than almost any opioid. It forcefully displaces the opioid molecule.
But because it's a pure antagonist.
Because it's a pure antagonist, it produces absolutely zero cellular effect of its own. It doesn't drain the battery, it just aggressively blocks the seat. And the moment the opioid is knocked out of the receptor, the neuron wakes back up. The electrical charge returns, and the patient's automatic respiratory drive kicks back in, often within just 2 to 5 minutes.
It is practically miraculous to witness. Someone can be completely cyanotic, turning blue, barely gasping for air, and minutes later they are awake and talking. But there is a massive myth associated with this reversal that we really need to address.
There is, yeah.
People assume that because naloxone saves your life, it is this peaceful, harmless medical intervention, like you just wake up feeling fine.
Oh, not at all. For a patient who is physically dependent on opioids, administering naloxone violently precipitates acute withdrawal.
It's immediate.
Yes.
Yeah.
Remember the mechanism. You are instantaneously ripping every single opioid molecule off the brain's receptors all at once. The central nervous system just goes into massive overdrive. The patient wakes up in severe
And they can be agitated.
highly agitated, combative, and they very frequently vomit, which presents a massive choking hazard for someone who is just regaining consciousness. It is absolutely life-saving, but it's deeply unpleasant. This is why paramedics and nurses prefer to titrate the dose slowly, giving just enough to restore breathing rather than slamming a massive dose that throws the patient into violent withdrawal.
And as miraculous as the reversal is, we have to talk about what happens an hour later.
This raises an important question, and honestly, it's the single most critical safety point in our entire pharmacological outline: the half-life mismatch. This is the phenomena of re-narcotization.
Explain that for us.
Well, naloxone has a notoriously short biological half-life. It is metabolized and cleared from the body in about 30 to 90 minutes.
But the opioid that caused the overdose in the first place might have a half-life of many hours. Methadone, for instance, can remain active in the system for over 24 hours.
Fentanyl patches continue releasing the drug into the subcutaneous fat long after the patch is physically removed.
The antidote wears off significantly faster than the poison does.
Exactly.
Going back to the musical chairs. The aggressive naloxone player eventually gets tired and leaves the room. The chair opens back up, and the fentanyl that is still circulating in the bloodstream simply sits right back down.
And the patient slips right back into fatal respiratory depression. This is why administering a single dose of community naloxone and just walking away, or discharging an overdose patient immediately from the emergency room, is incredibly dangerous.
Your reversal is temporary.
It is. Continuous medical monitoring for hours after the administration is absolutely mandatory.
You cannot just treat and street an overdose patient. So what does this all mean? Why does this deep dive into opioid pharmacology matter so much right now? It matters because opioids are going nowhere.
They really aren't.
They remain an absolute, irreplaceable necessity for surgical care and trauma management. Yet they sit at the center of the worst accidental death crisis in modern history. And with the widespread rise of community naloxone distribution, where this life-saving nasal spray is now stocked in public libraries, high schools, pharmacies, and coffee shops, this pharmacology isn't just specialized trivia for doctors and nurses anymore.
You, the everyday bystander, are now an active participant on the front line of defense. Knowing the toxidrome triad, understanding that the naloxone will wear off, recognizing that an overdose is fundamentally an oxygen deprivation emergency. That specific knowledge translates directly into saving lives in your community.
It really does. You might be the one standing there holding the naloxone when those seconds count.
And as we close this analysis, consider the profound historical irony of this entire timeline.
The irony.
Humanity's millennia-long search to understand the ancient Sumerian joy plant eventually forced us to look inward. It led us to map our own brain, to discover our own internal pain relief system. And it was the discovery of that precise biological blueprint, our own physical receptors, that gave us the knowledge to create both the most lethal synthetic chemicals on Earth and the only antidote capable of blocking them.
The very biological hardware that heals us is the exact same hardware that harms us. Like we said at the start, it's not a broken bone on an X-ray. It's a complex, precarious balance, and the margin between profound relief and absolute catastrophe is razor thin. Thank you for taking this deep dive with us. Keep questioning, keep learning, and we'll catch you on the next one.